Hi, everyone. Thank you so much for joining us today for Beyond the Blender, Optimizing Pediatric GI Treatment with Blenderized Tube Feedings. My name is Laura Doherty, and I'm the National Clinical Manager at Functional Formularies. And I'm really excited for the webinar we have for you today for a variety of different reasons. One, because over the time I've gotten to know our presenter, Dr. Reeves. He's fantastic. He has all these really exciting things that he's doing in his professional life, and he's going to get to share some of those with you today. And also just to hear it from a physician perspective, all about blenderized tube feedings, because usually we have a lot of dietitians that are our speakers, which are obviously amazing, but just to hear it from a doctor's perspective as well will be unique. Before we get started, a few housekeeping rules. This webinar is going to be recorded. The recorded version will be available on our website in upwards of 4 to 6 weeks. You will get an email indicating that the recording is available. This has been approved for one continuing education unit from CDR. So after the webinar, by the end of the business day, you will get an email from us. So there will not be something that automatically pops up giving you a certificate. It will come in a separate email. So just a heads up for that. If for whatever reason you don't get that email, please reach out to us. Everybody's going to remain on mute throughout the webinar, but at the end, we will have an opportunity for question and answer. So there is a questions option in GoToWebinar that you can type in your question throughout the webinar, and then Dr. Reeves and I will get to as many questions as we can. So with that being said, I'm excited to introduce Dr. Reeves to y'all today. He is a triple board certified in general pediatrician, obesity medicine specialist, and pediatric gastroenterology with advanced virtual care and research skills in patient education and the management of children and young adults with medical complexity. Dr. Reeves is the CEO of his consulting firm, Wild Child Medicine, PLLC. Love that name. He has a specific research focused on the development of mobile health technology called clinical action plans, which provides automated clinical decision support to medical teams and serve as low health literacy care plans for the home management of chronic needs. As part of today's webinar, Dr. Reeves is going to cover some of his clinical action plans. The information presented here and with regards to the clinical action plans, for example, the nutrition action plan, when we get to that section of the webinar, constitutes the intellectual property of Dr. Reeves. As such, these concepts and the presentation are not to be shared outside the agreed entities. Dr. Reeves is also a major in the United States Army. The opinions expressed by Dr. Reeves are his own, and the comments on this webinar do not reflect the opinions or positions of the U.S. government, the Department of Defense, or the Defense Health Agency. So with that being said, Dr. Reeves, I'll hand it over to you.
Hey, thanks so much, Laura. And it is my absolute pleasure to speak to you all today. And thank you to the Functional Formularies team for helping me create what I hope is going to be a very exciting discussion that we can have with regards to blenderized feeds. Laura already hit these big disclosures, but the consulting firm is receiving an honorarium. And although I am a member of the Department of Defense, nothing that I say here today should be considered the opinions of the federal government. Okay. So let's jump right into it. This is going to be really exciting stuff, I think. First, I want to end this webinar with you being able to accomplish 3 things. First, I'm hoping that this will facilitate your ability to formulate appropriate initial blenderized tube feeding plans for children and adult age children, especially those with medical complexity. I hope that we can help dispel some of the myths that come with the use of blenderized feeds, both commercial products and home blended recipes, so that we can use that evidence-based medicine to the enhanced care of our patients. And then finally, I want to help us evolve from just the hospital or clinic setting and determine what's the easiest and most practical approach, especially families that are initiating these blended feeds at home, and what tools do we have to use at the point of care at home to ensure safety and appropriate growth on these products. About me, I was born in Houston, Texas. I'm a native Texan and I currently practice in San Antonio. I am a Texas A&M University graduate. I was fellowship trained after going through general pediatrics residency at Walter Reed National Military Medical Center, which was really just a phenomenal chance for me to dialogue with world-renowned experts at Children's National, at Georgetown, and some of the other surrounding facilities. As was already mentioned, my research focus is in the development of clinical action plans. They're supposed to be tools, and you'll see them, that are very patient-centered but provider-driven, so that we help to take care that's very complex and boil it down to what's the simplest thing necessary and execute that in a realistic fashion at home. From an academic side, I am an associate professor of pediatric at multiple medical schools, and through Texas A&M, I'm also an associate professor of military medicine. I'm a proud husband and father of two, and fun fact, I'm also a carpenter. And so I think with any good webinar, we need to start with a research roundup. So what do the actual guidelines say? And I certainly would direct you to Aspen and the Enteral Nutrition Committee statement on blenderized tube feedings, because this guideline is easy to access and has chock full of good practical recommendations that will go through this webinar. Just as an aside, and the guideline statement from Aspen also does make mention of this, I want to make sure that we set the tone that when we're initiating blenderized tube feeds, a lot of the time we are doing this in patients with significant medical complexity. Some of them will have risk for aspiration or a history of aspiration. And so I leave this here as the standardized International Dysphagia Diet Standardization Initiative, the IDDSI, which should be a shared decision-making moment with the parent or caregiver, with your speech language pathologist, your RDN, and the gastroenterologist, all of whom are the medical team managing this feeding plan and ensuring that we are going to give a foodstuff that is safe for that patient to ingest. Next thing, there is some exciting, more recent evidence that is available for evaluation of patients with transpyloric or post-pyloric feeds of the jejunum. These are typically accomplished with a gastrojejunal feeding tube, but can, in rare cases, be done with a low-profile jejunal feeding tube. And this is just one of those recommendations that says that jejunal feeding tube from this reference is not recommended, but there is emerging anecdotal evidence that would suggest with appropriate dilution and good technical know-how of parents and home duty nurses, you could safely accomplish jejunal feeding through commercial blenderized feeds. The real trick is, does the pump and the tube cooperate in concert with the continuous infusion of that feed? And that's really what gets us to the next step. Size in the realm of blenderized tube feeds absolutely matters, but there's a caveat. A lot of the evidence that is out there and the practice recommendations which follow are specifically covering adult patients with low profile stomach level feeding tubes. And in most of those instances, you will see recommendations that 14 French or larger feeding tube is preferred for homemade blends. And certainly, there is both anecdotal and scientific evidence to support that the larger your French size, the easier it should be to infuse that blenderized feed. We can sort of take this logically and recognize that if we have a 16 French feeding tube, which is a pretty typical size for adolescents and adults, and we compare it to the smaller feeding size of an 8 French, you can understand that trying to use a syringe or another product to bolus feed this directly through the tube, the high viscosity of most of our commercial and home blended recipes might make it more difficult to do through an 8 French. However, I will say there is a select product on the market that is absolutely rated for 8 French feeding tubes. And so especially in those instances where we have infants who then have their first birthday and are 12 months or older corrected gestational age, a lot of them have 12 French feeding tubes placed by pediatric surgery. That would absolutely be large enough for a commercial blended feed, even if it's smaller than that, based on a select product. The next question I get most often with these initial starts of blended tube feeds at home is, how much time should we spend in the blender? Truthfully, 3 to 6 minutes is needed. And as you can see here, there's still some chunks the overall goal is to fully emulsify whatever is in that blend so that it is as homogeneous as possible, because that will be easiest to get through the valve of the feeding tube. So I think for most of our commercial blenders, things that you can get at your appliance store, 3 to 6 minutes is usually what we tell parents, and truthfully, 6 minutes is best. And hang time. Hang time is going to be different based on different products, but for the most part, you do not want that feed, that blended feed, to hang for more than 2 hours. The homemade blends can hang up to 12 hours, or sorry, excuse me, let me back up. The hang time for feed should be less than 2 hours if it's a home blended recipe, but if it is a commercial blended recipe, it can hang for up to 12 hours. I will say that my clinical experience is that most parents, even if they're using that commercial blended product, we're trying to infuse that meal in less than 2 hours so that we can better simulate what the table eating environment would be, and almost trying to simulate what our normal, the kitchen is open, we're at the table, we eat dinner, the kitchen is closed, and we do that in a finite period of time. So that's always a goal, is to try and simulate that normal nourishment dyad between parent and child. I think that's always just a social and soulful important part of the care plan to recognize. The next question that I get, and a lot of the time from excellent pediatricians and other primary care providers, is how do I know? Some of these kids will come to my clinic and they already have a feeding tube, and I've heard of blenderized feeds, but I don't really know who qualifies or what should I do? And thankfully, the joint position from the European Society for Pediatric Gastroenterology is very appropriate and has some blended diet recommendations, certainly giving you all of the steps you need to flow through and not only initiate these blended tube feeds, but continue the appropriate monitoring for the nutritional status, nutrient requirements, and making sure that no deficiencies are developed. And I am a huge believer that this is something that I hope we can open up to the primary care providers that are managing tube feeds, especially in resource limited areas of our country. So what do the guidelines actually say? What benefits do we get from either home blended recipes or commercial blended feeds? First and foremost, I can't footstep this enough, psychosocial benefits and the survey-based research that we have done with primarily parent caregivers of these patients is that they just are happier giving these types of feeds to their children. As you can imagine, there is a significant stigma that can come from certain polymeric and powdered commercial products. Be that as it may, the idea that parents are taking actual food, real food, and products that are organic, that are vegan, that are well tested with no additives, preservatives, or other unnecessary adjuncts added in, and giving their child actual food is something that really enhances, I think, that care plan and that therapeutic communication between parent and medical team. There's also some great evidence we'll go over that there is a myriad of GI symptom improvement, from retching, symptoms of gastroesophageal reflux disease, decreased vomiting, and normalization of defecation pattern. Blended feeds absolutely seem to be that great equalizer, wherein there is probably good positive microbiome potentiation, there's enhanced fiber, and the digestive process is probably altered slightly back to a normal signaling cascade to help with either resolution of constipation or diarrhea, respectively. And then finally, we have absolutely evidence to support reduced hospital admissions and decreased healthcare utilization amongst primarily pediatric patients who receive blended feeds. And that's likely related to the fact that we can decrease retching, GERD, and vomiting for children that have a history of aspiration. The blended feeds just appear to work that well. There certainly are risks, and I would caveat this by saying there's going to be risks with any therapy, and this risk should absolutely be mitigated by medical team members such as myself interacting with your child, teaching you, the parent, how to avoid tube blockages, to ensure that we're providing the adequate feed volume without excessively infusing high volumes to the child, ensure that we are avoiding different negative events such as medication absorption, and really trying to look at both the financial impact and food hygiene. I would say food hygiene for me seems to be most mitigated by leaning into and committing to a commercial blended product. However, it's absolutely safe to do home blended recipes. It just has to be done in a fashion where the gastroenterologist, the dietitian, and the parent form that triad and are able to stay in more regular communication with baseline rules to ensure that we're cleaning the equipment, we're attaining foods that are of high quality and not spoiled, and that we're using them in the appropriate safe fashion. And so let's go deeper into this, starting with the benefits. When we evaluate children that are receiving pureed tube diets, we have seen that 73% were seen to have a 50% drop in their gagging and retching symptoms. And if you've ever had a child either under your care or one at home who has had retching, this is one of the most distressing upper gastrointestinal symptoms that children can display. And so this is one of the first things that can be very helpful, because retching in children who've had a Nissen fundoplication to wrap their stomach around the lower esophagus, really this is the most distressing thing. We commit children to additional surgeries because of retching. So if we can improve this by giving them regular food, pureed, blenderized diets, and avoid surgery, that is a win-win. In addition, doing a feasibility study, a blenderized enteral nutrition diet was showed to decrease both the frequency and severity of vomiting, but also decrease the need of different acid suppressive agents, things like proton pump inhibitors and histamine 2 receptor antagonists. And that's really key, because we unfortunately do have a large proportion of pediatric patients that are on unnecessary acid suppression lifelong, it seems. That certainly places you at increased risk for gastrointestinal infections, things like Clostridium difficile infection. It increases your risk to have early onset osteoporosis from decreased bone mineral content. And there's a myriad of other potential risks for that unnecessary long-term acid suppression therapy exposure. Again, if we can use blended feeds to not only improve symptoms, but decrease the polypharmacy patients are on, that's a huge victory. When we actually take a look at the stool bacterial diversity, there's a significant increase in the positive microbiome colonies that we're looking for, and compared to some of the colonies that are seen to be more toxin forming, more destructive to the GI digestive processes like proteobacteria, those bad bugs, you might call them, look to decrease. And certainly, again, caregivers more satisfied and unanimously recommended blend tube feeds after the initiation. So across the board, we're making positive improvements for children with blended tube feeds. And the benefits don't stop there. In this rapid review by a Dr. Phillipson team, the blended tube feeds significantly improve family meal times. Again, we have an opportunity now to not just have children on these chemically engineered, high sugar, dye-based formulas. We are giving them real foods at the same time when they're at the table with their families, and their siblings and parents are eating whatever mom and dad cooked. And this is something that really enhances the care of that child. The perception of child well-being was significantly increased per the parents, and that was with limited support. And I think that's probably myth number 2 that's so important to foot stomp, is that blenderized tube feeds are safe, they're beneficial, and frankly, they're easy. This is not some sort of therapy that you're going to need a home nurse to be there for to start and stop. It's quick, it's easy, and it's mobile and easy to use at mealtime. So I think that's very key. And then this study from Phillips and team was able to show that children were able to actually tolerate larger volumes than they would have on their previous polymeric formulas. As far as stomach tastes the food and adjusting its emptying, There have been some studies, this one here from Papacosia, of some children exhibiting greater interest in oral feeds after starting blended tube feeds. This is just a correlation. We haven't really been able to establish causation for this, but as a guy who lives and breathes by the use of blended tube feeds for children with medical complexity, I am a firm believer that exposing your stomach to the foods that we're hoping to expose your mouth to probably leads to some sort of priming and signaling event where we're ready for it. It's almost like preconditioning before you go into the big sports game. It's probably preparing these children and enticing their gut to want to feed more after starting these blended tube feeds. And this is not a pattern that we've seen replicated with typical polymeric or even elemental based formulas. Blended tube feeds are really the only one that have been consistently shown to increase oral feeding autonomy in children. And when we look at other things, it's important to think about motility, which is the movement of food contents from the mouth all the way down the esophagus, small intestine, and then through the colon, and finally excreted as feces through the anus. That really most big component is around the movement of electrical signals through the stomach, and the stomach trying to empty those food contents into the small bowel. As you can imagine, a lot of the children that we use these feeds in have a history of intracranial pathology, be that history of prematurity leading to brain bleeds, causing cerebral palsy, or other potential forms of that. But if you have intracranial pathology or an atypical neurologic status, it is very possible that cranial nerve number 10, the vagus nerve, is affected. And when that occurs, if that negative effect changes the modulation of electrical signals, that cranial nerve 10 is also connected to the stomach. And that misfiring can mean that there's gastroparesis or functional dyspepsia of the stomach, and it can lead to these retching, vomiting, and tube feed intolerance symptoms that some tube-fed children exhibit, and it's because of that impaired gastric emptying. But what this study from Rosen and team was able to show is that there's no differences in gastric emptying when you compare blended tube feeds and typical polymeric formula. And the only other factor, which I don't think is clinically significant, is that there was higher gastric residuals with the blends. That's probably because to achieve the same caloric goal for a lot of these formulas, we have to do a little bit higher volume with these blended feeds compared to a little bit less volume for the non-blended, the polymeric forms. In general, though, I would say that in clinical practice, we have enormous amounts of data to show that checking gastric residuals should not be a standard vital sign or part of the care plan for children with tube feeds. It is fraught with complications like leading to suction of the bottom port of that gastric tube onto the gastric mucosa and causing bleeding, vessel tearing, and even buried bumper syndrome. So I never recommend gastric residual checking either in the outpatient setting or in the hospital. But I do think that there's some easy explanations for the increased volume of gastric residuals with blends compared to these other formulas, and I don't think it's clinically significant. Next, when we check in on parental perspectives, across the board, parents note improved health, improved growth metrics, which I think is the most key thing, but also resolution of negative GI symptoms and better inclusion, with a specific feature being that tube blockage with blended feeds is very, very rare. And that goes back to normal tube feeding practices, which we would hope to teach to each and every family. You need to make sure that you're flushing the tube after the use of a blended tube feed. You need to ensure that you're appropriately diluting the blends based on your particular French size. And if you follow those two simple rules, there really should never be tube blockages that occur. Next, when we actually look at blended tube feeds, while in this study from Sun and team, blended tube feeds did not demonstrate benefits of weight gain, it was also not associated with an increase in complications or hospital admission. And I think that's a very important caveat about the study to make, because there's many people who have subscribed to the myth that, oh, if I do this blended feed, maybe it's going to place that patient at risk for nutrient deficiencies. Or if I had a kid that I was doing continuous elemental gastric feeds on because of their aspiration, if I put them on blended feeds and if I can't accomplish continuous rates, maybe they'll vomit and aspirate. Clearly from this study, that increased hospital admission does not occur. And if anything, some of the recent numbers show that you have decreased hospital admissions for children on blended tube feeds. And finally, one of these review articles from Novak and team, blended tube feeds is not recommended for children with a jejunostomy tube. Again, we addressed this a few slides ago. That's a recommendation based more on anecdotal evidence. There is emerging evidence, especially on the adult literature, which would suggest that with the appropriate plan, dilution of the tube feed, and making sure that we have a large enough bore size for both the gastric and jejunal limbs, that you should theoretically be able to feed this through the jejunal tube. The truth of it is, we just have to be able to safely and reliably accomplish continuous feeds for blended tube feeds through a J-limb to be safe. If you can do that, there theoretically should be no problem. I just anecdotally would say that there would be high concern for risk of tube blockage, especially with some of the gastrojejunal feeding tube options that start out as a 14 French, but then taper in that J-limb to a 6 or an 8 French. So enough on the research roundup. Let's jump into some case studies, because this is my favorite part of these talks. So we have a 16-year-old male. He has had, per the parent, zero appetite for his entire life. And he has had extreme growth failure, as evidenced by this curve. And I met him about this point in his life. And he came to me on a standard polymeric formula with the request for him to drink 3 servings a day. And he was frankly drinking 0 servings per day. He was referred to pediatric endocrinology, who actually gave me a call before they saw this patient. And with evaluation, he clearly met the clinical definition of a chronic pediatric feeding disorder. And so what did we do with this child? Well, at his baseline, he had been on that polymeric formula. It was a 30 kcal per ounce variety. He was attempting 3 servings per day for the last decade. And you saw on the growth curve that that was not working. We had a transition plan. We were going to place a nasogastric tube because we had a high suspicion that this was chronic pediatric feeding disorder with an overlap of avoidant restrictive food intake disorder. And he was probably going to need a surgically placed G-tube by me. But in order to prepare his body for that, to ensure that we had adequate and safe wound healing, we needed to get him a little bit more plump before the surgery. I personally obtained an upper GI series, which is an outpatient fluoroscopic evaluation to prove that the gastrointestinal tract is appropriately positioned and rotated in the abdominal cavity before surgery. And then I took this child to my endoscopic suite and I placed a percutaneous gastrostomy feeding tube with my endoscope. And in that hospital admission, 8 hours after placing the feeding tube, he was bolused with his commercial blended product, and we transitioned him to 3 pouches per day. One of the interesting parts to put next to this growth chart, which shows growth failure, is some of the serum labs to sort of back this up. This had been a lab that I obtained around this time before we provided that feeding tube, before the nutritional resuscitation. And this is insulin-like growth factor. And what's important to know about insulin-like growth factor is it is a serum-based study that we use to evaluate if children have the ability to grow correctly, and it goes to whether growth hormone is going to be adequately secreted in their body. But one key thing is that this is at its base a protein. And if you are severely malnourished, as this child is, and if that malnourishment is a protein calorie-based malnourishment, then you can't really trust that they're not having growth hormone, they just don't have the protein building blocks with which to actually grow. And if you actually put them on 3 pouches of a commercial blended feed, one that's high peptide or high protein based, you can see that in a matter of, I think this was 60 days later, it comes back to the normal range. And so as you can see, again, I met him around here and we started our nutritional feeding plan here. And these were different clinic visits, but you can see commercial blended product up, 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 and away he goes like Superman. And I actually just followed this child up a couple of weeks ago, and he's actually above the 5th percentile for the first time since he was a newborn. And so for me, this is an important case to demonstrate importance of recognition of pediatric feeding disorder and recognizing that when traditional therapies such as oral formula supplementation fail, these children will benefit from feeding tube placement. And I am not asking myself, which formula should I put them on? What class is going to be easiest? My question is, I'm going to put them on a blended feed, and I need to ask myself, is there a reason why I shouldn't? And I've mentioned this a couple of times in the talk so far, but there is a specific diagnostic criteria for pediatric feeding disorder. This is from one of my mentors, Praveen Gooday, who did an amazing amount of work with our North American Society for Pediatric Gastroenterology Hepatology and Aspen, along with one of my other mentors, Dr. Jamie Fallon, to determine the framework for what constitutes a feeding disorder. You can see that our patient that I just presented fits all of these criteria. He certainly had more than 2 weeks of oral intake disturbance, and he has had metabolic dysfunction, which was primarily characterized by his growth failure and his low IGF-1. He had nutritional dysfunction manifest not just by his malnutrition, but other nutrient deficiencies that I was screening him for, and he did have reliance on that enteral feeding device going from nasogastric tube to the PEG placement. Notably, his feeding skills were not unsafe. He just wasn't using them, but still enrolling him into occupational therapy with feeding therapy was very, very important. And there was a significant psychosocial dysfunction, which was primarily manifest as attention deficit hyperactivity disorder. He was already on a stimulant medicine, and I made recommendations to his pediatrician to transition him to a non-stimulating pharmacotherapy, something that would help to control his behaviors, but not suppress his appetite. And that certainly has led to a boon in his oral appetite as well. And certainly the absence of other cognitive processes consistent with other eating disorders, things like anorexia, bulimia, and so forth. So I put this slide up because especially if you're one of the excellent dietitians in the audience, and maybe you don't have easy access to speech pathology or peds gastro, using this as a Bible for your screening tool for these types of children is very important, because the evidence shows that if they meet this criteria and if they need a feeding tube or are going to need that feeding tube for 6 weeks or longer, a referral to pediatric gastroenterology to facilitate that care is going to be in the child's best interest. And so how do we actually facilitate this care? We talked a lot of great concepts, I think, but from an implementation perspective, how do you get it done? This is a lot of stuff to keep track of, and I wonder if there's a resource that can help us. I think step one, especially for the dietitians in the audience, is educate the team. Here I have my first reference from Pediatrics in Review, which is an update on pediatric formulas. Commercial blended products and home blended recipes are absolutely safe, and you guys are the vanguard of this nutrition team and can help educate not just our pediatricians, but peds gastroenterologists and peds surgeons alike. There's many different types of gastrostomy feeding tubes, and this is another reference from Novak and team that really goes over that in fine detail, and that even I give to parents so that they can understand what our plan is now for feeding tubes, but what some of the rescue options might be in the future if needed. The basics of blenderized tube feeds, which I think is one of the most well-written articles from gastroenterology research here in 2019, still rings true today. And then finally, tube feeding in children gives a great overview of how to start these plans for children, whether that be in the outpatient or the inpatient setting. And if you're looking for a toolkit, our brethren across the pond have a great practice toolkit that you can Google this and find from 2021, which starts with initiation of these blended tube feeds in patients. Okay, step 2, after we've educated the team, we love the idea of blended tube feeds, is okay, who can we use blended tube feeds for? I have to say this gastroenterology research paper from 2019 is very good. I love the table. It is an adult-based recommendation, which is why you see 14 French or larger bore feeding tubes as the recommendation size for starting blended tube feeds. Again, big foot stomp. We can use smaller feeding tubes for children based on some products, and the option for homemade blends really does open up the avenue of this. When we get to some of the potential contraindications, acute illness and immunosuppression, that is something that I think would be medical team dependent. I have at least a half dozen children with various forms of congenital immunodeficiency that are on blended tube feeds, and they do phenomenally. The biggest thing is that I think the risk from infection from our immunology colleagues comes from the risk of improper preparation of foods purchased on the economy and brought into the home for a homemade blend. So we really do have to make sure we're washing foods appropriately and using appropriate food preparation hygiene. Fluid restrictions, that goes back to how some of the time we do need larger volumes for blended tube feeds to accomplish the same intended caloric goal compared to polymeric formulas. But I will say even in those children, we've been very successful with blended tube feeds because I think there's some enhancement of both gastric accommodation, gastric emptying that occurs with these blended tube feeds that isn't really out there yet in the research. And then we've talked about continuous feedings. Really, I think that if you can enact a plan that prevents the pump from alarming, that prevents the tube from clogging, there really should not be an impediment to continuous tube feeds of blended varieties. Okay, and I promised you a tool that we could use to enhance and facilitate implementation of blended tube feeds in a pediatrics clinic. So let me show you. This is our nutrition action plan, and this is where we'll end up. Let me step over to this real quick. Okay, so this is the nutrition action plan that I designed several years ago, and I use it with every patient that I encounter with pediatric feeding disorder or with a feeding tube of some kind, and I think it's quite fun. If we have a patient, we'll just call it little baby, you get to have Dr. Reeves and my office number, and let's say that this child is like a January 1st birthday. How exciting is that? You do today's date. You can put their MRN in here, which is super helpful for parents who don't want to have to log into the patient portal every time. And maybe we'll say that they're 5 kilograms. Now, this has not just things for the parents to use, which is like the green zone for your basic feeding plan. It's got options for medications if you want to add those in. It's also got some yellow and red zone. Basically, if this happens, do this. So some of our babies, unfortunately, will have vomiting. So if vomit times 1, then pause feeds for 4 hours and restart. It might be as simple as that. We may use medications, who knows? The point is that you can really customize this to your child's needs. It's not just an easy one-sheet summary for the parents. It also provides some safety limits for providers. So for instance, if I want to show the Naspagan reflux guideline down here from Dr. Rosen and team, you'll see that for the most part, we don't need to use acid suppressing medicines in infants. But if I were to click select medicines, I want to put this on the chart for the baby, you have this safety warning that I've embedded to show that you need to review that reflux guideline and ensure that this is really what you want to do before ordering that medicine. Now, beyond the safety stuff that's provided, we do have the IDD-SI embedded to this as well, as you can see down here, and a link that takes you over to the Aspen website and all of the infant approved formulas. But let's do the next piece. Let's say that we are going to have this baby be fed by a nasogastric tube. You can see that it actually populates a picture of a baby with an NG feeding tube because you want this plan to depict what these parents are actually going home with. So if it's a G tube, well, we would change that so that it's actually a G tube. Or if it's a baby with a gastrojejunostomy feeding tube, you can do that as well. You can see how it changes here. This is when we might enter our feeding tube stuff like it's a 16 French or a Mickey 14 French and 30 centimeter J-limb and a 1.5 centimeter G-limb, something like that, and placed by IR on whatever your day was. That's what I tend to do just so that I have it in the chart for the parents and they know what they're getting. Let's make this though just a little bit simpler. We'll do a G-tube. And the question is, what are we going to feed this kiddo? Well, unfortunately, and I hope this is different in the future, and this is a talk on blended feeds, we do not have any blended feed varieties FDA approved for infants, even though, of course, we are giving complementary foods when kids have appropriate head and neck control. And so hopefully that's something that will change in the future. What if we were to change the age of this patient, make them a little bit older? You can see how the plan automatically updates everything, goes from infant formulas to pediatric ones. It even changes the reflux guideline to the older child version. So let's go back. We'll do that G-tube again. How cute is that? Sorry, it's literally the best part of my day is clicking these buttons. It's so much fun. Okay, so we're gonna go down and again, all of the FDA approved formulas are on here, which is super, super important, I think. But what you'll see is a recreation of what I did for another patient that we'll go over. And if we were gonna say that we're gonna do like a whole pouch and I just use the mLs by weight, and we're gonna do this by syringe, and let's say we're gonna do that every 6 hours, okay? Or maybe you wanna change that to 4 times a day. You can see that the tool takes the product, you don't have to do any mixing, it tells it for you, and it's taken the volume and frequency of infusion and calculates for you the total daily volume, the free water derived from just this here, and the total daily calories. You can see that based on a 5-kilo person who is 15 years old, that the numbers get off. So it's important to make sure that we are entering accurate information so that the tool can do what it needs. Now, this is more physiologically appropriate. You can see that with just the feed alone, we're still short about 700 milliliters of water. And if this is a child who's really not going to drink water, then you would add that in and you can see we're much more appropriate. And so the important thing we would add to their plan is something like need to add 700 ml free water every day. And that's how I start. And I walk the parents through the idea of you're doing 4 feeds a day. So that might be like 150 mLs 4 times a day. So that's 600. And then you've got 100 mLs left over to flush after every feed. And that's how you accomplish the 700. The other great part about this tool is you can do a dot phrase on your EHR, and you can actually put all of the medicines in there that you might need. And if you have a child who's doing blended feeds and IV parental nutrition, it's got a second page for parental nutrition. Okay, back to action. I'm gonna wait a few seconds so that the GoToWebinar can catch up, but I'll describe what's on this screen, which is one of my medically complex patients who has a congenital liver disease called Alagille syndrome, who also has autism spectrum disorder and chronic pediatric feeding disorder with malnourishment, who came to me a couple of years ago. And so I used this tool to give him a high protein, high MCT content based blenderized tube feed to enhance his feeds. And you can see that we were not only doing blended tube feeds, but we we're also giving him oral calories, always trying to enhance the child's ability to take things by mouth and become autonomous for their own nutrition by mouth and rehabilitate that gut day after day. It also gave me a chance to capture his medicines here. And I think that's what's so important to recognize is feeding is complex. It's very complex. And there are other advocacy organizations of which I love partnering with, like Feeding Matters, whose job it is to help educate about pediatric feeding disorders, but also to provide parents and providers with resources to appropriately manage these in the long term. And so if you've never heard of Feeding Matters, I highly recommend that you Google them and go on their website, because it is just a wealth of resources, both for the medical team, providers, and the parents. And that's because up to 45% of typically developing children can have decreased appetite or potentially fall into that category of pediatric feeding disorder. This is from 1995, and a little bit more recent, up to 80% of what they in the past called developmentally disabled children have feeding struggles. And so it is an enormous unaddressed part of our population that is needing this type of specialized care. And it's my opinion that by simplifying the care with the nutrition action plan, that you can really help parents solidly give that nutrition at home to enhance the growth and development of their children. Okay, so this is where we started with that patient number 2. You can see that there was concern for this particular child with diarrhea. And so I was able to put, if it's just diarrhea, call us. And if it's diarrhea plus fever, you need to go to the emergency department, especially if it's after hours. And then it was important again to recognize that the parents who had initially given this child 1 pouch a day, we increased that to 3 pouches. He was growing. And I think based on that higher number of pouches, the higher blended tube feed volume, we're able to distend his stomach more regularly. We're able to probably correct some of the hormonal signaling between ghrelin, which is for hunger, and leptin, which is for satiation, that come from the stretch of the stomach. And then eventually we started decreasing his blended tube feed calories while we were increasing his oral feeding calories. And as I mentioned, that was a 4-year-old child with Alagille syndrome, autism spectrum disorder, and significant growth failure. And he started with 2 pediatric oral meal replacements daily, but it really just wasn't enough. And when we transitioned him from nasogastric tube feed to percutaneous gastrostomy feeds and immediately started with those whole food blenderized pouches, he immediately responded both in growth metrics, but also in appetite. And this was without the use of appetite stimulants for a time. When we started to pull back on the blended feeds and went back from 3 a day to 2 a day, I do tend to empirically offer cyproheptadine as a potential appetite stimulant, and that seemed to work very, very well for this child. And in all, the other fun part was this chronic liver disease seemed to improve. I didn't change his medicines, didn't change doses. All I did was help this child grow and achieve a more appropriate BMI for his age, and his liver numbers miraculously got better. It's almost like food is medicine. There are some barriers to blended tube feeds that I think are important as take-home points for this. First is that there's going to be a conversation about cost. And I think it's also a misnomer that blended tube feeds are going to be more expensive than other commercial formulas, but at least based on this 2011 study from Pentiuk et al., blended tube feeds were cheaper per day compared to commercial formulas. So take that with you. When we actually break this down, you can see that average daily costs in 2021 showed that homemade blended tube feeds definitely cheapest, commercial blended feeds about $50 a day, but commercial polymeric formulas, either liquid or powder-based, were 3 times as expensive. So this is probably our most recent cost metric on blended tube feeds. And I would say if you're looking for something that is right for your patient, something that's safer, better, symptom improving, and cheaper is probably the way to go. There are some administration barriers, and I think that starts again with the medical team. It's on us as providers because there has been in the past an overall low level of confidence, be that not very confident or not confident at all, in 73% of providers that were evaluated in this clinic among both physicians and nurse practitioners. The majority of clinicians in the study were willing to support blended tube feeds, but because they felt like they lacked the know-how and the education on this, they weren't really ready to recommend these feeds, which is important for us to have webinars like this and going on campaigns like with Feeding Matters and other groups to ensure that providers are aware that this is a great option for most patients. Other administration barriers can be experiences and perceptions of multidisciplinary teams, from 2/3 being aware of blended tube feeds and really about the same percentage having cared for a child with blended tube feeds, and only 70% willing to recommend blended tube feeds. This study is from 2024, and so this really is, I think, recent data going to show that we're still missing 30%, more than a quarter of our providers in these multidisciplinary clinics do not feel willing to recommend blended tube feeds. We've got to do better. And I think part of that is not just the voices of everyone on the team being heard equally between the speech pathologist, the primary care physician, the dietitian, the gastroenterologist, but it's also our parents. And hopefully our parents can come in, and I've had this before where, man, we are immediately on the same page. Parents come in and they have a picture printed off from the website of a commercial blended product they want their child on, and I'm like, let's do it. Also, 3 and 5 of those providers stated they were somewhat confident in their blended tube feed knowledge, but only 1 in 5, so less than a quarter, were not competent in managing children on blended tube feeds. It is absolutely my hope, and take this as the tube feed gospel. I am hoping that in the next 5 to 10 years, that especially our pediatric gastroenterologists who are completing training will absolutely feel confident managing blended tube feeds as a solo provider, especially if it's of a commercial blended variety. There are some hints and tips that I'll leave you with at the end of this. We've gone over most of them about clogged G-tubes, ensuring that we have really well blended any homemade varieties we make, but always flushing the tube with water, especially after giving medicines and feeds. There is some anecdotal suggestion that there's increased wear on these G-tubes, and so ensuring that we're checking that the balloon is functional, that we're changing these tubes out every 3 to 6 months is very important. We also want to ensure we're avoiding foodborne illness. That goes back to appropriate hanging time durations for both homemade and commercial blended varieties, but also preparing these feeds safely. Nutrient deficiencies are fairly rare, but appropriate serum-based laboratory analysis should occur on a regular basis, probably every 6 to 12 months, especially for children on blended tube feeds. One is, of course, checking carnitine, magnesium, phosphorus, but another, especially for children who have a risk for malabsorption, who are not growing but are on excessive calories, checking a urine sodium is very important to ensure that we are providing enough salt in the diet, because if the urine sodium is low or undetectable, that indicates a depleted total body sodium, and that in and of itself can cause growth failure. So you have to correct it by adding salt into the feed. As I mentioned, there are many patient advocacy organizations out there, including Feeding Matters and the Oli Foundation, and I highly recommend, if you've never engaged with these wonderful groups, to do so, because it certainly has been to the betterment of my care for patients as a gastroenterologist. And I'll leave you with conclusions before we do questions. First and foremost, I would always screen children with feeding issues or gastrostomy tube for pediatric feeding disorder. We have excellent guideline-based recommendations to help coordinate care from Aspegan and Espegan. Blended tube feeds improve a variety of GI symptoms. We need to grow clinician confidence using blended tube feeds, and these blended varieties, whether homemade or commercial, are more cost-effective than standard formulas. And I hope that you were interested in the Nutrition Action Plan. Hopefully that can make a splash and improve care for the better of these children, especially those with blended tube feeds. And if you're looking for a place to find either the video that explains the tool or where to capture it, there's that QR code, and I'll come back to that. but I think we're ready for questions and hopefully some meaningful answers.
Great. Thank you so much, Dr. Reeves. Thank you for sharing your knowledge, and your passion is just contagious. So that was fantastic. We do have a few questions, so let's dive in. The first one is, for those patients who have been on your standard formulas for many, many years, 20, 30 plus years, so some of those really complex medically patients, is it safe to assume that their GI tracts can still digest real food and using a blenderized tube feeding would still be okay?
I would say there's probably two parts to that. Is that one, we don't know. So if there are children with very specific allergic disorders, we typically have identified one or more food triggers. So I'm talking about things like eosinophilic esophagitis, or maybe a more distributed eosinophilic gastrointestinal disorder, especially if it involves the small intestine. The good thing is that the most common food trigger for those kids is going to be dairy, which is not going to be present in some of the best commercial blended products we have. So I would say for the most part, I will give samples to those families and say, hey, if you want to walk this journey with me, let's try this. There's a good bit of evidence to say your child should do great on this, but if there's anything that happens, please go to the emergency department, right? This is not something you should try when you're out of town on vacation. The second piece of that, though, is that especially for children who come to us and have been on a very specific polymeric formula, powder formula, what have you, for many, many years, it can sort of be a shock to the system to go immediately from that, generic brand polymeric formula to the blended one in a 24-hour period of time. So typically what we do is we set a plan over a matter of weeks so that we're down titrating the polymeric formula and we're equitably up titrating the blended feed. One, I think that just helps with overall toleration. It improves the digestions, especially when we bring them back after a month or so and their growth metrics are improved. But it also helps us to avoid any issues that might come from ripping the rug out from underneath the child's feet, so to speak.
Yeah, no, thank you for that. I think one of the things I also did when I was still practicing is starting with just adding some baby food to their current formula, and really starting there with something like green beans comes to my mind off the top of my head. Is super easy to digest. Let's start there, or avocado or something like that.
Yep. No, I totally agree. Avocado is usually my go-to, sweet potato a second, and then for dessert, mangoes.
Yeah, perfect. The next question is, there's a few questions on this just for clarification purposes on the French sizes. The guidelines say 14 French, manufacturer guidelines are different. So can you just clarify the French sizes, what is okay, what isn't okay, and when you can use which?
Absolutely. So I think the most important thing is that the French sizes that are recommended are just recommendations. And so most of the guidelines that are out there are on adult management. And so that's why several of those tables say 14 French or greater, 14 French or larger bore size. The truth is that you need to know each product, because there is especially one product that I use most frequently that we can certainly do lower French size. And I all the time hey, it's your first birthday, here's your blended tube feed on your 12 French feeding tube, and it works phenomenally. So a lot of the commercial products can be even smaller feeding tubes, even down to 8, but it is product dependent. I think the biggest take home is it is not a blanket policy. You do not have to be 14 French or higher. It's probably going to be easier if it's 14 French or higher, but it should not be a no. It should be how do we make this work? How much dilution is required? Will your child tolerate this increased volume without high risks? And most of the time, absolutely.
Okay, great. Can you share any clinical experience you have with using Blenderized tube feeding for short bowel syndrome patients?
Yes. So we traditionally have had children with short bowel syndrome on either elemental formula, which most of them don't need, or a peptide-based formula. So my N of 1 that we really wanted to do this with was on a peptide-based commercial blended feed formula. Again, tons of great MCT and fat content that is in that particular product, and this kid was amazing. we had gotten to the point where continuous feeds weren't necessary anymore. We'd really rehabilitated this bowel. He had already had a citrulline level that was well above goal, so the likelihood for intestinal adaptation was high. So he was a great candidate to begin with. And so when we switched from continuous feeds over to bolus feeds, I went with this commercial blended product, and he never looked back.
Okay. In what inpatient scenarios is blenderized tube feeding contraindicated in your opinion? So just speaking inpatient wise.
Hmm.
It's a good question.
It is a great question. So as you've seen from the research I presented, there is evidence that there's decreased vomiting, that gastric emptying is the same. It's not that these commercial blended products are going to require significantly longer time to empty from the stomach. And so I will say that traditionally the evidence for children with concern for retrograde aspiration, we're going to vomit our stomach contents all the way up our esophagus and then back into our lungs. Traditionally, we will try and either use prokinetic therapies like erythromycin to enhance emptying. If it's a stomach tube, we'll even put that stomach tube on a continuous infusion and try that. I will say that in the outpatient setting, if we have tried those things and it's not working, my step 2 is to say, hey, let's give this commercial blended variety by bolus a try. Truth be told, I have not tried continuous infusions of blended tube feeds in my clinic population yet. It's something that I'm waiting for the right patient to come along. But I would say that there's probably very, very few times when I think that you could not use blended tube feeds if you are starting feeds in a patient. Certainly, if you've got a patient who's rule out bowel obstruction or in the midst of some intra-abdominal abscess or peritoneal disease or something like that, that you're not going to feed them anyway, well, then you kind of already decided they're getting no food into their GI tract. They're probably getting parenteral nutrition. Other than that, I would say my comfortability based on my experience is to try continuous gastric feeds with prokinetic therapies for management of inpatient gastroparesis. But we have tried plenty of patients who don't tolerate that as well. We put them on a commercial blended product a few weeks later, and that works, and we never look back. You could try commercial blended products first line. I don't think that there's any reason to say that's unsafe.
Yeah, and I think it's an evolving area. And there's Dr. Johnson out of Troy just did a really interesting article about BTF and policies in the hospital, and really most facilities didn't even have a policy. So I think that's step 1 is getting a policy in your hospital about how to use BTF. And then I think the other thing that's hard about BTF in the hospitals is there's not a hang bag, right? And that is a convenience factor over anything else. So I think it's an area that we'll see some changes in the future, hopefully. Last question, do you have time for one more?
Oh, certainly. No, I will say just on that most recent question, I'm very spoiled because I have 2 different brands of commercial blended feed on the inpatient formulary, so I can do whatever I want.
You are spoiled. So when somebody comes in, like pediatric patient comes in, gets a G-tube, can they be started on a BTF, as their first formula right after the tube is placed, like within 24 hours, 40, whatever this, I know when I was still working,
Absolutely.
every surgeon was different in terms of when you could start feeds, but
Yes.
Can that be the formula?
Yes, absolutely. And I would say in the first 24 hours. So luckily we have just an awesome, relationship, myself and our pediatric surgeon at our institution. 100% of the post-op G-tubes are managed by me. So whether I surgically place it or our surgeon does, I'm the one managing it post-op, which is great because that means that it's my pediatric residents that are hustling through that care, and we're using the same protocol every time. And so the typical way that it's done, and the timing changes per surgeon, changes per institution, but for the most part, we place that G-tube, And then the patient's going to be in the recovery area, the post-anesthesia care unit, for 2 to 4 hours. And so we usually say surgery was completed at 8 a.m. Okay, I typically will have that tube clamped for 4 hours. And so just, closed if it's a balloon G tube. And so that means it's noon. And at noon, we initiate some sort of clear fluid through there. We typically go with an electrolyte containing fluid. So take your pick, be that Pedialyte, Powerade, Gatorade, any commercial product out there. We get them up to their full maintenance rate of fluid support because surgery is stressful. You have insensible water losses. So we make sure to keep them hydrated. And then I keep them at that continuous rate for 6 hours. And then once they've proved toleration of the clear fluid, we transition over to whatever polymeric formula we're going to use. And of the 3 or 4 we have on formulary, it doesn't matter to me really. I put them on something that they've probably had before, and I keep it at that same continuous rate, giving them actual calories, macronutrients, proving their guts tolerating it continuously, no vomiting, for 6 more hours. After that, we do a 4-hour pause, make sure everything empties from the stomach, and that next time is 99% of the time the blended tube feed. So if you start this journey at 8, then usually the next morning breakfast is your blended tube feed. And my protocol is you tolerate breakfast. If you want to go home, bye-bye.
That's great. You should publish that protocol.
Maybe. We'll see. We should do it together, Laura.
Okay, we can certainly do that. Well, this has been fantastic. I really appreciate all of your time, Dr. Reeves, and to all of our attendees. Thank you for sharing the last hour with us. Like I said, you will get your continuing education certificate in an email by the end of the day. You also get a copy of the slides and the references, and we just really ask that you all take a survey to give us feedback on today's event so that we can continue to have engaging presenters like Dr. Reeves and just continue to improve our offerings to y'all. So thank you, Dr. Reeves. Thank you, everyone. And we'll sign off.
Thanks so much, everybody. Have a great rest of the day. Bye-bye now.
Bye-bye.